Hello and welcome to everybody on today, our International Stop the Pressure Ulcer Day. On behalf of the Tissue Viability Society, we'd like to welcome you to the fourth and final in our series of Stop the Pressure Ulcer skin webinars. This and the others in the series will be available from the TVS website shortly following its presentation. Our series is based on skin, S-K-I-N, the first being focused on S for skin assessment, for those with darker skin tones, K for keep moving, where we shared best practice for caring for patients nurse prone, I for increased moisture, where we focused on the skincare and barrier protection, and today will be N for nutrition and hydration, where we will focus on hydration for this year. So let me introduce you to Karen Green, who works at the University Hospitals Leicester. She's a deputy sister there, but the chief nurse and a chief nurse's fellow. And she also won an award this year. And this award was for the Patient Experience Network, a national award, Professional of the Year 2021. So welcome today, Karen. We look forward to your presentation. Thank you.
Okay, I hope everybody can see those okay. So, as Tina said, I work at the University Hospitals of Leicester. I work on a 28-bedded gastroenterology ward, specialising in nutrition, hepatology and luminal gastroenterology. It's a large teaching hospital and we are based within the East Midlands. I'm currently involved as the Trust's Chief Nurse Fellow Programme and have been looking at ways of reducing hospital-acquired harms by improving hydration within the Trust. The project originated as part of the Trust's Pressure Ulcer Collaborative Programme, and I've extended this for the Chief Nurse Fellows Programme. So why is hydration important? The role of hydration in both wound healing and pressure ulcer prevention is well documented. What is less well known is the link between hydration due to the effect of dehydration on blood volume and skin turgor. Fluids are responsible for providing the transport of vitamins and nutrients from our nutritional intake to and waste products away from cells within the body, as well as allowing oxygen perfusion, hydration to wounds, and cushioning joints. Fluids are also used to regulate body temperature, moisten eyes and mucous membranes. If the body doesn't get enough fluids, it simply cannot make use of even the best nutritional support that may be in place. And by the time red flags start to appear, the damage may already have been done. Fluids are lost at a volume of approximately 2.5 litres a day, 1 litre through breathing, sweating and defecation, and around 1.5 litres through urination. These losses are usually replaced through drinking and through foods we eat. These values can vary, however, depending on factors such as exercise and extreme temperatures. The body is usually able to maintain a balance of loss versus intake. Sometimes, though, this balance is disturbed, leading to dehydration. When patients are in hospital, fluid loss can be even greater. This is secondary to surgery, losses of fluids through wounds and drains, high output stomas and intestinal conditions, leaking peripheral edema. Patients may also find it harder to replace their volume of fluid loss due to an inability to access drinks as freely as they normally would, a decreased sense of thirst due to aging, fluid restrictions, or periods of nil by mouth. Dehydration can have significant effects on the human body, many of which either go unnoticed or can easily be ignored due to busy lives and a false idea of how long it takes to become dehydrated. Dehydration is classified into 3 types: isotonic dehydration, which is usually caused by diarrhea and vomiting, leading to an equal loss of water and sodium throughout the body. Hypertonic, where there is a total loss of body weight caused by reduced intake and pathological fluid loss, or hypotonic, which is characterized by extracellular fluid loss caused by a predominant loss of sodium in the body, most commonly seen in renal disease, diuretic use, and reduced intake of water and sodium. 60% of total body weight in humans is made up of water. This is held within the intra and extracellular compartments. It's the fluid in the extracellular compartments which is first lost when dehydration occurs. This all suggests that proactive prevention approach is needed rather than a reactive restoration one when addressing the problem and the associated risks of dehydration. Dehydration occurs when more fluid leaves the body than enters it. It can often be caused by acute illness, long-term medical conditions, or the medications used to treat them. Even low levels of dehydration can cause headaches, lethargy, and constipation. Other signs of dehydration include dry mouth and eyes, increased capillary refill time, tachycardia and hypertension, decrease in the production of tears and sweat, muscle cramps, nausea and vomiting, heart palpitations, weakness, or dizziness due to postural hypotension. Common signs many of us will experience every day, and these include an increased thirst and a reduced amount of dark coloured urine. This is the body's way of trying to encourage intake and reduce output. During a study in 2014, it was found that 37% of older people are admitted to hospital and are found to be dehydrated. Of these, 62% were still dehydrated 48 hours later. It also found that this dehydration led to an increased risk of mortality in the acutely unwell, and a risk of further illness and harm was also increased. These harms include UTIs, seizures, AKI, hypovolemic shock, and an increased risk of falls and pressure ulcers. A couple of facts that are worth remembering about dehydration. It only takes a 2% loss of water within the body to cause you to feel thirsty, and this is already a sign that you are dehydrated. Mild dehydration also means that you are 114% more likely excuse me, to make an error. And this risk is of a similar risk to if you have drunk low levels of alcohol. Although skin can be both dehydrated and dry at the same time, it often presents with very similar symptoms, but they are significantly different. Skin can be dehydrated but still be oily, and it can be dry without being dehydrated. Dry skin is usually characterized by a lack of natural skin oils and sebum being produced by the cells. It's genetic, the hair follicles are not dilated, pores remain small, and skin has normal functioning. Dehydrated skin, however, is often caused by diet, lifestyle, and environmental factors which lead to high fluid loss. It can be dull in appearance and may feel tight due to less elasticity. It can be flaky or sensitive. Normal functioning of the skin will start to break down with dehydrated skin, leading to further moisture loss, decreased production of and turnover of skin cells. Keratinocytes in the topmost layer of the skin lose their efficiency and allow external irritants to enter. The appearance of dehydrated skin under a magnifying glass resembles dry, cracked soil. Many patients on gastroenterology wards are dehydrated due to their illnesses and conditions, but this can be said of countless other patients in hospitals in all specialities. I wanted to know if this risk could be easily identified through a nurse-led risk assessment, which would highlight who is at risk through illness or age. I found within acute hospital trusts, patients are not formally assessed for dehydration on admission or throughout their stay, unless blood tests are being taken. These blood tests can cause discomfort for the patient, and they incur financial costs for the trust. Through internet searches and database searches, I discovered that there is a risk assessment already in existence and is used in some areas of the country in community settings. It's called the GULP Risk Assessment Tool. This tool was developed by the Food First team at the South Essex Partnership University Hospitals Trust. And with their kind permission, I was able to adapt this tool for use in acute hospital settings and produce relevant care plans. Following 2 PDSA cycles of this tool, peer reviews and adaptations, consultants who specialise in nutrition and intestinal failure, senior dietitians, and the deteriorating adult response team was asked to peer review the tool. I appreciate this is not a particularly clear picture of the tool, and over the next few slides, I will break the tool down and explain its use. So the first element of the GULP risk assessment tool is to assess the patients twice weekly. This means you can monitor them throughout their stay on a regular basis and pick up early signs of dehydration. You use the patient's previous 24-hour oral intake and measure this against their minimum suggested fluid requirement based on age and weight. If their intake is greater than their minimal requirement, they score a 0. Less than their minimal requirement, but greater than 1,000 mils, score is 1. And less than 1,000 mils, they score a 2. This can be estimated by asking how many cups of drink they've drunk, but ideally patients should be on an oral fluid intake chart. It is important to note, however, that requirements do vary based on height, weight, age, and medical comorbidities. The second part of the assessment is an assessment of the patient's urine colour using an attached urine colour guide. Colours 1 to 3 with no smell or several wet pads a day for incontinent patients score 0. If you're unable to assess the patient's urine due to non-compliance or a discoloured urine colour secondary to hematuria or jaundice, or there is a smell occasionally or 1 to 2 wet pads a day, the score is 1. Colours 4 to 8, very strong smelling urine, or very few wet pads throughout the day, and the score is 2. Part 3 is an assessment of current signs of dehydration that you can visually pick up, such as some sunken eyes, dry mucosal membranes, and looking at any existing acute or chronic illnesses or medications that put the patient at a higher risk. A score of 0, 1, or 2 is again given based on the guidance information on the risk assessment. Scores for each section are then totaled to give an overall risk score, and an appropriate care plan can then be implemented. The aim is to increase the patient's oral hydration. So there are some exceptions when using the tool, and it's important to remember that if at any point you are clinically concerned regarding the patient, you must speak to the medical team to see about the potential of intravenous fluid replacement. So the exceptions to the tool: if a patient is on IV fluids, only oral fluids should be counted when assessing the GULP scores. If the patient is started on an oral fluid restriction for any reason, could be due to cardiac or renal problems or high output stomas, the assessment should be discontinued until that fluid restriction is lifted. If a patient is nil by mouth, the assessment should be put on hold until oral fluids are restarted, unless enteral nutrition is in place, in which case you can continue the assessment using the enteral input for the fluid input section. I started using the tool on one patient on the ward, and this pilot lasted for a period of a week before I expanded it. The patient started off in a significant negative cumulative fluid balance, and during this first week, the patient showed a reduction in her GULP score. She went from a high score of 6 to a medium score of 3. The patient's oral intake steadily increased on a daily basis until days 5 and 6, where there was a decrease. This was followed by an increase in the patient's negative cumulative balance, demonstrating a direct correlation after approximately 48 hours. Following this, a further 5 patients with different medical conditions, mobility, statuses, and different baseline GULP scores were added to the trial and monitored from admission to discharge. The trial pilot was then expanded, and I followed 6 patients from admission to discharge. 5 of the 6 patients showed an element of dehydration on admission to the ward. 3 of these 5 showed an improvement in their GULP scores pre-discharge. 2 of the 5 remained at the same risk level, but 0 patients had a decline in their oral dehydration status. I then looked at the effects of the increased oral hydration on patient Waterlow scores. And in the sample group of 6 patients, 50% had an improvement in their Waterlow score. Now, this may have been directly influenced by their hydration. However, there are other contributing factors, such as an improvement in their general medical condition, removal of certain medications which cause higher risk. And it's important to remember that correlation does not always equal causation. The pilot is currently on a 6-month trial, and this is now involving all patients admitted to the ward, following them from admission to discharge. We started in July, and I will finish the trial at the end of December. The results so far have been really positive when compared to the previous number of pressure ulcers which have developed on the ward over the past 3 years, as you can see on the slide. It's important to mention, however, that the 2 yellow highlighted months for the year 2020, the ward had a different patient base. Due to the COVID-19 pandemic, the ward became a COVID admissions ward, meaning that on average, patients were only on the ward for 24 hours. So the data for these 2 months, for the year 2020 of July and August should be disregarded. There have been some limitations to the pilot. As with anything, when you try and introduce a new assessment, new piece of paperwork, a new process, staff initially felt that they didn't have time for it. They were under too much pressure already. This was resolved by allocating the assessment to be completed on days where staff were not already completing set assessments. And this was decided to be Tuesdays and Saturdays. The pilot has been quite limited to only gastro patients and needs to be trialled in other areas. A 6-month period is not really long enough with such a limited sample group of approximately 100 suitable patients a month to fully explore the potential benefits of the tool. Another problem I found was the Trust currently has a paperless system for all patient assessments. However, the GULP was completed on paper. This meant that sometimes the forms were filed in medical notes on discharge and sent back to coding, which caused a delay in data collection. Finally, I'd like to give you a few tips on improving patient hydration. So by actively monitoring all patients on an oral fluid input chart, you can pick up patients who are potentially at risk and may not be meeting their requirements. It doesn't have to be an hourly input. It can be, if the observations are being taken, you can make it part of the observations, as you would ask a patient if they're in pain, ask them how much they've had to drink since the last set of observations were taken. The use of the national red tray and red lid system can also help. This clearly makes it visible to all staff which patients may need further assistance to help have a drink. Providing a wide variety of drinks which patients can access 24/7, such as sugar-free squashes and juices. Avoidance of caffeinated and sugary drinks. Encouragement to drink at every patient interaction. And patients just sipping very small amounts of fluid regularly can soon improve their intake and build up to a large amount. The use of a dehydration risk tool with regular reassessment and a visible identification of risk level at bed spaces can prompt staff to assist patients to see which level of risk they are and which care plan is appropriate for them. For patients that may have sore mouths or following oral surgery, sipping fluids through straws can make things easier for them. The avoidance of spouted beakers for the sake of using them. Patients are often given beakers when they're not needed. This can cause a reluctance to drink, and it can also lead to an aspiration, as people are not used to the flow they produce coming out of the spout. Providing a patient with a prompt record card, such as the flower shown here, and asking the patient to colour in a petal for every glass of fluid they have drunk, with an aim to fill all the petals by the end of the day. A 200 ml glass 8 times a day would equal 1,600 mils. A few further sources of information. Some of the studies that I looked at. Thank you very much. That's the end of my presentation. If there's any questions.
Hello, everybody. If you'd like to stop sharing, that would be grand.
Done.
Brilliant. Thank you there, Karen. Thank you very much for that presentation. And for those hints and tips about how we can improve hydration for our patients. Now, for everybody else, if you have any questions for Karen about how she's introducing her project, any comments that you might have, because I'm sure that Karen would like to hear about your experiences also, could you please type those into the Q&A box or the chat box? I'll get started on some questions that we already have here. Now, the first question is, unsurprisingly, is can they have a copy of the slides from today and maybe the previous sessions? Can I remind you that all these presentations will be available on the TVS website or on our YouTube channel, which is TVS UK, I believe, or TVS TV. So this and other presentations will be found there. So Karen, can I ask you about the patient's urine colour? Because we do have to rely a little bit sometimes on patients reporting that for themselves when they've taken themselves off to the toilet and things like that. How do you manage there if the patient isn't really supporting that process and isn't very compliant? How does that affect the use of the tool?
What I tend to say is, if a patient isn't particularly compliant, which quite a few of our patients within gastro are not for various reasons, provide them with a bottle. They can go to the bathroom and use that. If they're still not complying with that, I would say you score them as a 1. You go with the unable to assess due to jaundice, hematuria, area of the tool. If you're always scoring a 1 for that section because they continue to be non-compliant, you will still see an improvement or decrease based on the other elements of the tool.
Mm-hmm. I mean, dehydration is really important, or hydration is very important, should I say, in the prevention of pressure ulcers, in that it makes the skin tissues much more resilient to pressure. Now, you seem to have had fairly low levels of patients with pressure ulcers in your ward. Is that because your introduction of the GULP tool actually went alongside lots of other pressure ulcer prevention strategies being put in place?
There has been other prevention strategies put in place over the past few years, and the Trust has been working quite hard to improve these things. We have, as part of the pilot I'm currently doing, I'm comparing against a control ward, another gastroenterology ward, which received the same training as we do, same doctors. So we've tried to minimise the amount of variables that there can be. And that area has had more pressure ulcers than we have, not just over the past 4 months that we've been doing the pilot, but over the past couple of years. So there are other factors potentially which do fall into it, but we do try to, as we are linked together as a ward, try to conduct the same form of training, so all staff are receiving the same training.
Mm-hmm. So, I mean, most areas are trying to prevent other harms as well, and hydration is not just about prevention of pressure ulcers. There are lots of other harms that are done by patients. Have you noticed that introducing the tool, the level of those other harms has reduced as well?
Yeah, my full Chief Nurse Fellowship project is also looking at falls and the level of falls that are had, again, compared to previous years, but also compared to the control ward. And our area has had a significant number of less falls since July than the control ward. And again, all the variables are kept to a minimum. Different times sort of affect different things. And again, the couple of months we had last year during the COVID admissions unit bit, we didn't see as many at all, but again, we had a much smaller client base and patients were on the ward a lot less, but there has been a decrease in falls as well.
Mm-hmm. So Lisa has asked whether some patients who require thickened fluids, does this change the way it's used within the body to rehydrate?
I'm not sure if it changes how it actually rehydrates. One thing you do have to be careful with thickened fluids is it obviously reduces the patient's appetite, fills the stomach more, so patients do tend to have less nutritional intake. But I don't know if it has a less hydrating property by being thickened. I'm sorry. Something we can look at, try and get back to you if you like.
Yes. Actually, is it Jana has asked whether you have any tips for those with dementia? Any additional tips for those with dementia? I'm not sure that's your patient group, but
no, we don't have a huge number of patients with dementia that you would classify as your normal type of dementia. We do, however, get a lot of patients who have hepatic encephalopathy, Wernicke's, Korsakoff's dementia, which is usually caused by high levels of alcohol intake. I would say, try and use the flowers, colouring flowers, but just every patient interaction. If you go in a bay, encourage somebody to have a drink. That's the main thing, and try and get everybody on board, be that doctors, physios, domestics, anybody. Anybody can walk into a bay, go to a patient, see they're at risk, and say, oh, do you want to have a little drink while I'm here, and help them. It doesn't have to just be down to nursing staff.
I have to say that having cared for my father-in-law with dementia, and he was a very reluctant drinker, and probably wouldn't work well on your ward where people have difficulty with alcohol, but actually giving him a beer, something that he actually enjoyed enjoyed doing and chatting with a beer in his hand, he would actually drink a lot more. Obviously, I'm not suggesting that we fill our patients full of alcohol ever, but you know, when we're looking at people with dementia, it's about finding sometimes the thing that actually they enjoy doing along with a drink, and that can make a big difference.
Yeah, I was just going to say, I think also looking at what you're giving patient drinks in, so not only the removal of spouted beakers when they're not needed, but we have found, in one case I can think of specifically, we had a lady with Down syndrome admitted to the ward for nutritional problems, and she was quite reluctant to drink. We happened to do something called posh tea rounds on our ward, so we had got fine bone china teacups. We gave her drinks in a fine bone china teacup with a saucer, and she drank from those. So it's trialing different things as well. Not everybody wants to drink out of a polystyrene or, you know, plastic disposable cup. So things like that, speaking to relatives, finding out if they normally drink their tea out of a specific vessel, you know, can also help.
Yeah. I have to say that I did get fairly interested when I found someone who was producing sweets, like jelly sweets, to encourage fluids, until I worked out that my father-in-law was going to cost me £10 a day in sweets.
They are very good, but they are very expensive.
That's right. And I'm not sure his pension was going to go to £10 a day on the sweets, but you know that for some people those sort of things can be useful and helpful. Lisa's you know, mentioned about the visual prompts around for dementia and encouraging people to drink as well. So thank you for that, Lisa. I think it's you know, like a lot of things, we find ways to adapt those tips really that Karen gave initially to the client group that we're looking at, and we're all individuals, aren't we, Karen? So you know, what works for one doesn't necessarily work for the others. Jana has asked about using the skin turgor test. I think they're sort of like talking about the pinch test. Do you use that at all when assessing dehydration?
We don't. The reason for that is, particularly with the elderly, their skin loses elasticity anyway as they get older, so it isn't always a reliable tool for testing dehydration, because the skin will naturally not bounce back as quickly.
Yeah, I mean, one of the difficulties with dehydration is it can happen fairly quickly to individuals, can't it? When we talk about malnutrition, you know, diet can take a lot longer to have a positive or negative effect, whereas dehydration is much quicker in the day. So pinching somebody once a day probably not too helpful, as you say. Now I think we've run out of questions now, Karen. So I'll bring this webinar to a close. Thank you very much, Karen, for sharing with you your important project. And for those of you that are thinking of introducing something new, those steps that Karen's taken and has demonstrated throughout her project, starting off slow and working her way, increasing the numbers, and look at the time Karen is spending introducing this, you know, think about those things. Thank you very much for your time and for sharing with us your important project, Karen. Thank you very much to everybody else for being here today. As I say, International Stop the Pressure Day. So if there's one thing you can go and do out there, one person that you can tell something and share that will help reduce the number of pressure ulcers out there, please go ahead and do that. So thank you very much, everyone, for your time. Goodbye.
Bye.